Hello, anatomy students. This is your simple anatomy teacher coming at you today from West Claremont High School, room 227. And today we are going to discuss airflow through the lungs, lung capacities, the different volumes of our lungs, and how oxygen is transported by our blood. And that is going to be our main topic for video lesson 4. So without further ado, let's go ahead and get started. All right, guys, welcome to the next video in the series on the respiratory system. Today, we're going to talk about airflow and some of the things that can affect airflow through the respiratory system. Differences in air pressure drive airflow, but 3 other factors also affect the ease at which we ventilate. And again, remember, ventilate is simply bringing air in and out of the body. First is surface tension of the alveolar fluids causes the alveoli to assume the smallest possible diameter and accounts for 2/3 of lung elastic recoil. All right, elastic recoil, remember from the muscular system, when we talked about muscle cells having elasticity, elastic recoil is when the air leaves the lungs due to the increased pressure. By decreasing the volume of the thoracic cavity, the pressure goes up. The air will then leave your lungs and the lungs will recoil, which means they go back to their resting size. And that causes the alveoli to reduce in size. Normally, the alveoli would close with the expiration and make our work of breathing insupportable, which means if the alveoli collapse, then being able to reinflate them would be virtually impossible. So there is a fluid, a substance called surfactant, that lines the inside of all of the alveoli and prevents them from collapsing during expiration. It does not matter how forcefully you exhale, the alveoli will always remain open and spherical, similar to a bubble. And that is what enables us to re-inflate our lungs when we take a breath. So surfactant prevents the complete collapse of alveoli and exhalation, facilitating reasonable levels of work. And this is why breathing is not that hard for us to do. The second thing that can influence airflow is lung compliance, which means the lungs and chest wall expand easily. So not only do the alveoli need to expand and not totally collapse, the lungs also will need to expand, and your chest cavity will need to expand. In one of the classes, we talked about how it's impossible to lie on the bottom of a swimming pool and breathe through a hose. And the reason is the water pressure compresses your chest to the point where you cannot expand your chest enough to get over that, to get under that 760 millimeters mercury to decrease the pressure to allow the atmosphere to push the air into your body. So you can try, but the water is just too heavy and it squeezes your chest too much and makes it impossible to breathe. So that's one of the things that can influence taking a breath. Other things that can influence that is a broken rib that will, the pain of trying to take that breath will limit how much you can expand your chest, and just the breakdown of the structural integrity of your chest by that broken rib will make that more difficult. And there are some diseases such as pneumonia and emphysema, which make it more difficult for the lungs to expand. The third factor is the same as in the blood vessels, is the diameter of the airway. The less the airway resistance and the greater the flow of air. So the lower resistance there is in the airway naturally will give us an increase in the airflow. Now that's pretty, you would think would be pretty self-explanatory. If the bronchioles dilate even a little, the resistance drops by a power of 4. So basically, a small dilation or an increase in the size of the bronchial tube will increase the flow of air by a power of 4, and that's pretty noticeable difference. Of course, the opposite is true if the bronchioles constrict, and that reduces the airflow. And you can ask anyone with asthma how much of a difference that will make. This is due because of, in the formula, D4, which is the diameter in the equation, dealing with the airflow, and so the resistance is inversely proportional to the power of 4 in that formula. The diameter of the airway is regulated by smooth muscle tone, which is dependent on the stream of sympathetic or parasympathetic tone. And of course, sympathetic is what you control, and parasympathetic is what is controlled by your subconscious, your autonomic component of your nervous system, what is not under your conscious control. Ventilation can be measured by using spirometry. There are a couple different tools that you can use. Our lab from the other day shows us that you really don't need very fancy equipment to get a good idea of these different volumes, but there are a few very fancy devices out there. Obviously, the one we used with the balloon and the ruler, not so much. Tidal volume, or VT, is the volume of air inspired or expired during normal quiet breathing, or eupnea. On average, this is going to be about 500 milliliters. Inspiratory reserve volume, the IRV, is the volume inspired during a very deep breath. An inhalation can be up to 3,100 milliliters, and this is dependent by height and gender. Typically, a taller person is going to have taller or bigger lungs, so they're probably going to be able to inspire more than someone who is shorter. So, someone who's 5'1", their chest cavity is not going to be as long as someone who is 6'8". So that, and typically in most instances, your males are taller than females on average. So that's going to be one of the things that can influence their larger lung capacity. The expiratory reserve volume, or ERV, is the volume expired during a forced expiration or exhalation. And this is when you go to blow out those birthday candles and you just have those 1 or 2 left, and you just have that last little bit of air that you are just so forcefully trying to get out of your body to blow that candle out so that you can get your wish, probably spraying saliva all over the top of the cake. But, don't think about that when you're eating birthday cake. That's where you get into your expiratory reserve volume of roughly 1,200 milliliters. Vital capacity is the air that can be exhaled after maximum inspiration. So this is an extra amount of air that you breathe in is an extra amount of air that you can breathe out. That is pretty self-explanatory. It is the sum of the inspiratory reserve plus the tidal volume plus the expiratory reserve, and that comes out to be a grand total of 4,800 milliliters. The residual volume, RV, is the air still present in the lungs after a forceful exhalation. So no matter how hard you exhale, you can't create a vacuum. You try, but it's just impossible here on Earth to create a vacuum inside your chest, because the air is always there. Air is all around us. And you can force out all you want, but there's always going to be a little bit of air left over. Now, if you've ever had the quote unquote wind knocked out of you, then you have had someone help you create a lower volume of your chest, which of course increased the pressure way above what you normally can do by just muscle contraction. And that dropped your volume drastically. And it takes you a couple breaths to bring back your residual volume. And that's what getting the wind knocked out of you is. So you can do it with help, but you can't do it really by yourself. And again, residual volume is the air still present in the lungs after a forced exhalation, and that's going to be about 1,200 milliliters. So the residual volume is reserved for mixing of gases, but is not available to move in or out of the lungs. So it's the air that's always there, is how I always like to say it. The air that's always present in your lungs, the amount of air. It's not the same air, but it is the amount of air that's always present in your lungs. So here's a graph that shows the difference between a tidal volume and our forced exhalation and our forced inhalation. So this section of the graph is the tidal volume. This is normal quiet breathing. This is just while you're sitting there listening to my velvety voice trying to describe the respiratory system. You are probably involved in just tidal volume or eupnea breathing, and you're just basically moving about 500 milliliters of air in and out. All right. If you go to take exhale a lot, say if you are blowing out those birthday candles, you can dip down into this area in your expiratory reserve. But usually before you do that, you have to take a big breath up here. So that is your forced inhalation, and that gets up into your inspiratory reserve. So when I told the story about my deep dive at the Bahamas, I tried to take as big of a breath as I could because my goal, again, was to swim down to 60 feet. And, in the story I told where the barracuda came over and all that good stuff, I went down to 63 feet. So I made a series of deep forced inspirations to get as much oxygen into my lungs, as much air into my lungs as I could. And then, of course, by the time I got up to the top, I had to give a forced exhalation to get rid of that because I really, really needed to take a breath. Only about 70% of the tidal volume reaches the respiratory zone. Remember, anything that's trapped in the trachea or the bronchial tubes is called the respiratory dead space, and no gas exchange takes place. The other 30% remains in the conducting zone, also known as the anatomic or respiratory dead space. And again, gas exchange will only take place in the alveoli. Any air left in that anatomic or respiratory dead space will not lose any of its oxygen. If a single vital breath of your residual or your tidal volume breath equals 500 milliliters, then only about 350 milliliters will exchange gases at the alveoli. So that means 150 milliliters left over will still contain its oxygen. In this example, with the respiratory rate of 12, that would be how many breaths you take a minute. The minute ventilation is 12 times 500. So in a minute of just normal, quiet eupnea kind of breathing, you're going to exchange about 6,000 milliliters, or for those of you who can navigate through the metric system, 6 liters of air in that 1 minute. The alveolar ventilation volume of air by minute that actually reaches the alveoli then will be 12 times 350. So you're only, out of that 6,000 milliliters, you're only going to get oxygen out of about 4,200 milliliters, again, depending on height and gender. Using the gas laws and understanding the principles of ventilation and respiration, we can calculate the amount of oxygen and carbon dioxide exchanged between the lungs and the blood. And you can see in this diagram, it tells you how much. So you have in the oxygen, you've got about in the blood. You have about 98.5% of all of the oxygen absorbed is going to be attached to hemoglobin on the blood. The remaining 1.5% of what we absorb into our blood is going to be in plasma. And then that blood will go out to the tissues and drop off the oxygen, pick up CO2, and then is released as CO2 in the lungs. And you can see it's different. Not all of it is going to be on the hemoglobin. Really only about 23% of the carbon dioxide that we breathe out is going to be attached to the red blood cell. The rest will be dissolved in the plasma. Even though the air we breathe is mostly nitrogen, very little dissolves in the blood due to its low solubility. So nitrogen goes in, nitrogen goes right back out. Decompression sickness, also called the bends, is a result of the comparatively insoluble nitrogen being forced to dissolve into the blood and the tissue because of the very high pressures associated with diving. By ascending too rapidly, the nitrogen rushes out of the tissue and the blood so forcefully as to cause vessels to pop and cells to die. So there would be lots of internal bleeding on the microscopic level because that gas that was due to the high pressure was pushed into your blood will start to bubble out, and there's no room for it. And in those small capillaries, they begin to rupture. Transport of oxygen and CO2. In the blood, some oxygen is dissolved in the plasma as a gas, about 1.5%, not enough for us to stay alive. Not by a long shot is that enough to keep us alive. Most oxygen, about 98.5%, is carried attached to hemoglobin. Oxygenated hemoglobin is called oxyhemoglobin. So as soon as that blood cell picks up oxygen and it attaches to the hemoglobin, we now refer to it as oxyhemoglobin. And you can see this red blood cell here, and you can see the oxygen goes across the capillary bed in the alveoli, and we pick up oxygen and we drop off CO2. CO2 is transported in the blood in 3 different forms. 7% is dissolved in the plasma. 70% is converted to carbonic acid through the action of an enzyme called carbonic anhydrase. So the formula is CO2 plus H2O yields H2CO3, which yields hydrogen plus HCO3. 23% is attached to hemoglobin, but not at the same binding sites as oxygen. So hemoglobin has binding sites for oxygen and has binding sites for carbon dioxide. Okay, so that is how we get oxygen into our blood and into our tissues. And that is going to be it for video lesson 4. All right, that's going to do it for video lesson 4. As always, if you have any questions, simply shoot me an email and I will do the best that I can to answer those questions for you. If you are home on quarantine, this will get us through what we've been doing in class. If by some reason we are on remote, then head on over to Schoology and look for that exit slip. All right. Thanks for watching. We'll talk to you later.